morning all. Thank you to the organizing committee for giving me this opportunity. I consider it an honor and privilege. The only complaint I have is I have been given to talk after Dr. Bansi Sabu, who is one of the giants in the field and has covered most of it. But let me point out some practical aspects as a nephrologist. Wonderful talk, Dr. Bansi. So, I'll be talking about recent advances in diabetic kidney disease, and you might be thinking what is left after Dr. Bansi's lecture. So let us point out some other advances as well. We all know for a nephrologist, diabetic kidney disease is extremely important. It's the commonest cause of chronic kidney disease. And chronic kidney disease, 17% of Indians are affected by chronic kidney disease. It's as common as diabetes, but we are unfortunately not aware of it. 2 lakh Indians need dialysis or transplant every year. 2 lakh, whopping figure. And how many are we doing per year? 15,000 transplants. Dialysis, how many are we doing? Around 1 lakh. What happens to the remaining? Dead. So it's very important to prevent chronic kidney disease, and DKD is one of the major drivers. Not only that, not only dialysis and transplant, huge cardiovascular morbidity and mortality, and the cost of dialysis and transplant, you all know. Do you know that in Ayushman scheme, which is the topmost consumer of health budget of India, it's not oncology, it's not cardiology, it is dialysis, hemodialysis, and our economy is getting shattered by the numbers of patients on hemodialysis, and the major cause is diabetic kidney disease. So now, what was traditional and what's new? So we know the first point is screening for diabetic kidney disease. We all know that type 2 diabetics from onset and type 1 diabetic after 5 years, we should start screening. And we were taught urine albumin creatinine ratio more than 30 was abnormal and EGFR less than 60 was abnormal. This was what we were traditionally taught. Is there any new thing here? Yes, there are 3 new important developments in the field of proteinuria. One thing is many of the centers across the world and in India do not have UACR. Most of us do urine protein creatinine ratio, and now we have an equation, online calculator, by which you can easily calculate the UACR from UPCR. That is advancement number 1, which we should be aware of as Indians. The second important thing is point of care. So now CKD has been made as one of the NCDs in India, and the screening of CKD has to be made available at primary care centers, and even in your clinic, you have point of care testing for albuminuria. So these machines are important, and they, along with the UACR, give you creatinine, EGFR, even the glycemic parameters, lipids, etc. So this is a good tool to have in your clinic setting. The third important thing is Dr. Bansi already alluded to. Gone are the days of 30 milligram per gram and all that. Now we know that you have non-albuminuric kidney disease as well, and it is equally bad. It also causes dialysis and transplant. And 30% of diabetic kidney disease is non-albuminuric. No proteinuria, no albuminuria. How do you pick it up? Only by doing EGFR. This is slightly different from the albuminuric diabetic kidney disease. You know, on that side, you have proteinuric or albuminuric diabetic kidney disease. You have more common in males, smokers, they are obese, central obesity, high cholesterol levels, and generally you have glomerular lesions and lot of proteinuria. The glomeruli are involved in the kidney. Whereas you have non-proteinuric, where it's more common in females, elderly, non-smokers, short duration of diabetes, and generally associated with macrovascular complications. And here proteinuria is not there. Why proteinuria is not there? Because glomeruli are not involved. Here tubules and interstitium and vessels of the kidney are involved, and that's why you have non-proteinuric diabetic kidney disease. The treatment is not much different because we don't have much evidence for treatment of non-albuminuric diabetic kidney disease. The treatment pretty much remains the same, but prognosis is poor, and still the treatment is evolving. The second important recent advance is in the form of EGFR. Here we all are aware, and we are all now doing an EGFR. That's good. Even on prescriptions we are having EGFR, where we do it in the mobile phone. Until now we were told creatinine is the gold standard. But now what's latest here, that if you have an obese patient, malnourished diabetic patient, bodybuilder, smoker, wherever they are too fat or too thin, the best thing to do is a cystatin C, and you have equations based on creatinine plus cystatin C combination. So initially you do EGFR creatinine, but if any of these conditions are there, also do a cystatin C and calculate the cystatin didn't see creatinine epi-EGFR. It's again there on the online calculator. So this is the advance in the form of creatinine. What about staging? This we have seen since almost 5-10 years. KDIGO staining, you know, G1 to G5, depending on GFR, and A1, A2, A3 albuminuria. So what's new here? This KDIGO staging, we must all know, you should write on your prescription. But what is new here? This KDIGO screening tells you at that point of time how severe is the kidney disease for that individual. But you have now KFRE. And what is KFRE? Kidney failure risk equation. Because many patients will ask you, doctor, how many years down the line I'll go into kidney failure? You can easily calculate the risk of kidney failure at 5 years for that individual. So it gives a future risk. So not only KDIGO scoring, but KFRE is also important. So that's new. Then about HbA1c, you all know, in CKD you may have falsely low because of hemolysis, you may have falsely high because of uremic toxins. So CGM has come in a big way in CKD patients, especially if the sugars are very fluctuating and the target is time in range at least more than 70%. So the green band between 70 to 180 milligram per DL, that's the zone we target for. So this is about some of the advances in screening and diagnosis of proteinuria, of eGFR and glycemia. What about management? How do these translate into management? Some of them have been covered by Dr. Bansi. The key concept is not only glycemic control in a diabetic, it's holistic management. Treat the person as a whole, go for organ protection. And that's why we talk about CKM, which Dr. Bansi already mentioned, cardio, renal, metabolic. So previously nephrologists were never invited in roundtable talks for cardiovascular disease, but they are now being more and more invited, and that's the correct approach, a teamwork. And we also speak of the 4 pillars, RAS, SGLT2, non-steroidal MRA, and GLP-1RA, this Dr. Bansi discussed. This should get fixed in our minds. Now, my viewpoint, some important things. RAS is the first player of protection. We don't even talk about it. But remember, here also we have something new. First thing, use maximum tolerated dose. Telmisartan is 80 mg. Inapril is not 10 or 20. It's 40 mg for renal protection. So don't use baby doses. The second thing is, traditional teaching was discontinue if GFR is less than 30. That's stage 4 CKD. What's the new teaching? The STOP ACE trial shows do not stop ACE even till GFR of 15. That's the second important point. Now we have new potassium binders to control hyperkalemia. And the good news is, by the end of this year, we'll have them here. Sodium zirconium cyclosilicate. This is expected this year in India. The advantage is you can use it for long periods of time. As of now, we have calcium rhizonium or polystyrene sulfonate. All of them cause colonic necrosis. We can't use them for long term. This can be used long term and continue with your RAS blockers. The second pillar of protection is GLT2. I need not tell all the benefits. Reduces blood pressure, glycemia, renal work, renoprotective, cardioprotective, so on and so forth. So SGLT2 should be a part of every prescription of diabetic kidney disease, provided the GFR is less than 20. Is more than 20. Less than 20, we don't use it. More than 20, yes. And remember, previously we used to talk about albuminuria, but here with or without albuminuria, SGLT2 should be on your prescription before the patient leaves your clinic if the eGFR is more than 20. And we have evidence, Credence, DAPA, EMPA. Here, important things for postgraduates. They are all similar trials. Credence is for early CKD. DAPA is for more severe CKD. The cutoff for Credence for CANA was 30 GFR. For DAPA, 25 GFR. And EMPA, GFR till 20 and without albuminuria. So EMPA is the only trial among these three which has included patients without albuminuria. So now SGLT2 for non-albumic patients also, provided the GFR is more than 20. So this you should remember about these three trials. Another pillar of organ protection is GLP-1RA, that is the gilamonester from which it's supposed to be derived. They are also very good renoprotective drugs, reduce oxidative stress, natriuretic, diuretic, decrease inflammation, decrease weight, BP, glycemic, cardioprotective, organ protective. So very good drugs, the third pillars. And we have the FLOW trial, and we are proud to say that I was one of the PIs in FLOW trial in India, and we had a very good experience. So flowing with the semaglutide, the FLOW trial. So again, where do we use it? Either you can use them instead of the SGLT2 or after SGLT2 if the glycemic control is not attained and if the patient is albuminuric. These drugs can be used again in these patients as well. And we did the trial. The trial was with injectable semaglutide. Unfortunately, injectable is not available in India. We have oral semaglutide available. Some renoprotective trials are there, but no major renal RCT is there with oral semaglutide. So as of now, it's not in our guidelines presently. Injectable semaglutide is yet to come. Is it only semaglutide? No. There are so many other GLP-1 RAs, and you have trials, Rewind, Excel, Harmony. So you can see the colors. The green color shows that those drugs were useful in early CKD. The orange color shows even in moderate CKD very effective. And the pink color shows they were effective in severe CKD as well. So the crux of this slide is all GLP-1 RAs equally effective across spectrum of CKD, cardioprotective as well. And now the new molecule is GIP and GLP agonist, tirzepatide, much talked about in endocrinology conferences, not so much in renal conferences, because as of now we don't have a trial. Again, here also it's supposed to be renoprotective. SURPASS-4 trial is there, but as of now it's not come as a part of renal guideline, but this molecule is also a future molecule and we are eagerly awaiting an RCT for this. So we have talked about the glycemic control and organ protection, and that's why it's not only metformin alone, SGLT2 and GLP-1 RA. SGLT2, I already made my point. Remember how important it is. See the sentence in yellow. If you start SGLT2 at a GFR of 85, you give 26 years of dialysis-free life to the patient. 26 years. So it's a criminal act if you don't start it early. At 85, the patient will be with you, not with the nephrologist. It should be started early. And again, if the targets are not attained, you can add, as I said, GLP-1 RA as well. Fourth pillar, Dr. Bansi has talked about Finrenone, non-steroidal MRA without any side effects, can be used for all diabetic kidney disease patients with one caveat. Albuminuria should be there. It's not tried and tested for non-albuminuric CKD. It's not for use in non-diabetic CKD. So Finrenone, important thing is hyperkalemia, potassium ensure should be less than 5 when you are starting Finrenone. If the GFR is less than 60, 10 mg dose. If GFR is more than 20, more than 60, 20 mg dose. Is it available in India? Yes. Dr. Sabu already told that. But once you start, how much time will it take for the albuminuria to come down? It takes roughly around 3 months. Once it has come down, should you stop it? No, you have to continue it. So that's important. So probably it will be needed for life. So as I said, start with a GFR more than 25, serum potassium less than 5, and albuminuria should be there, more than 30. And the patient should be on maximally tolerated dose of RAS blocker. And this is confidence trial, and here again as a nephrologist I speak with confidence. Dr. Sabu told what it was about. We were also PIs in this global clinical trial. We randomized a good number of patients, and I can confidently say the combination of SGLT2 and Finrenone is the way to go. There was a whopping reduction in renal outcomes, and this would be the combination of the future. The next advance is about a CV risk score. This is the PREVENT score calculator available online. Whenever a diabetic patient comes to you with CKD, please assess the cardiovascular risk as well. And if I start a statin, that's important. Do that calculator. We are not writing the CV risk on the prescriptions. I do not find it written in any of the prescriptions. That's it. So last slide is there are some other advances. Bicarbonate trial. So please add bicarbonate to the prescription if the serum bicarbonate is less than 18. Anemia, we all know now the TSAT targets are 40%, ferritin should be raised to 500. This can be done by physician. And desidustat, what is it? Oral erythropoietin. It's available, 100 milligram tablet alternate day in place of erythropoietin. So this can be used for anemia. And mineral bone disease, what else is new? We know about calcium, phosphorus, vitamin D, PTH. We know all that. What's new? DEXA. Look for osteoporosis in patients of CKD. It's very, very common, and you have molecules more than than 35 GFR bisphosphonates, less than 35, you use denosumab. So these are the important changes. And the last but not the least is vaccination in CKD. We are all aware, hepatitis B, pneumococcal flu, chickenpox. Then what's new? New is on 15th August, we are having launch of Prevnar 20. So need not give 2 doses of pneumococcal single shot over. So that's the 10th advancement. So ladies and gentlemen, what I have told you today, this is how your prescription should look like in 2025. Proteinuria, UACR or UPCR, purchase a point of care kit if you can. Check for creatinine cystatin if obese people do that GFR. Do a kidney DIGO scoring and also a kidney failure risk equation. It's all available online. CGM versus HbA1c used for your patients if fluctuating sugars. Organ protection remains the key. Calculate a CV risk score. Maintain bicarb 18. That's forgotten many of the times. Use decidustat for anemia and DEXA scoring, and Prevnar 20 is on the horizon. So these are the 10 recent advances which can be applied by the physicians, diabetologists, or whosoever sees these patients. We are doing, in a government hospital, 3,000 dialysis per month. We have a spoke center which is doing 5,000 total per month. So we are doing 8,000 dialysis per month. We are doing around 800 transplants completely free. Do you think we should be proud of this? Initially we were so happy. But we have realized dialysis expenditure is the highest on national level, state level, even more than cancer and cardiovascular disease. So should we celebrate or speculate? I think the latter. We should speculate. It's not our success. It's a failure of the system. We have to prevent CKD. And how do we do that? By diagnosing early, treating early, by avoiding kidney failure. And this can happen only if we have a teamwork. And that's why we are all here. Prevention is better and definitely cheaper than cure. I again end saying a good doctor does dialysis, a better doctor maybe even transplant. But who's the best doctor? The person, the doctor who prevents his patients from going in for dialysis or transplant. So thank you for a patient hearing.
Thank you, ma'am. So that was a great talk on the recent advances in diagnostics and treatment, and also ending up with a 10-point thing to take home messages. So thank you once again. That's a wonderful talk. So we'll have some questions.
I think we'll have a discussion of both the talk together at the same time.
So first, ma'am, I would like to congratulate you for a wonderful talk, because you not only highlighted the science, you have put it in the right perspective that prevention is the key, and advocacy again is not establishing in dialysis centers or celebrating that we are doing so many dialysis. So many dialysis means that we are failing somewhere in preventing the disease. And I see a lot of physician diabetologists sitting here, and you have explained wonderfully the flow. I would like to understand, ma'am, for a clinician who is sitting in the clinic and is getting a GFR, because KFT is a report which is patient will always agree to do, because the kidney function test is a very common test done, and the patient themselves, they come and ask, doctor, please check my kidney, whether they are all right or not. So many of the labs, they are still not giving eGFR report. So what is your message to all the clinicians that if you are looking at the creatinine alone, probably you are going to miss the first step in assessment of the diabetic kidney disease?
So that's a very valid point. So I request all the physicians, for the benefit of the patient and for your benefit, to avoid legal problems later on, the eGFR should definitely be written on the prescription. Now insist the labs to do it. That would be easier. Otherwise you have to take out a minute and do it on your cell phone. It's that important, because all the strategies are based on the level of GFR. And if we don't even know, creatinine 1.8 could reflect a GFR of even 40 or 30 depending on the patient. So the creatinine is misleading and GFR is mandatory. See, nowadays patients can sue you. They'll say, doc, I have been your patient for 10 years. I was a diabetic. I was coming to you and you never checked my eGFR. It's already available online everywhere. Patients are educated. And I think it's our responsibility not only to avoid legal consequences, but for the benefit of the patient. Because remember the statement, if you start the drugs, the nephroprotective drugs early at a GFR of 85, you are going to delay dialysis by how many years? 26 years. So if you were to be a patient, many of you might be diabetics here, Wouldn't you want those nephroprotective drugs in your prescription? Definitely yes. So why not for our patients? So GFR mandatory. No other opinion or thought about it.
But yes, we also should not forget urine albumin creatinine ratio, because what is happening is still eGFR, and most of the labs now they started doing, because we are talking for eGFR almost like 20 years or more than that, but still urine albumin creatinine ratio is completely missed, and when patient comes little later, then they develop. She had given very nicely the 10 points and where it including the vaccination. But my suggestion is that no, someone should develop DKD and then we start vaccination. No, every diabetic patient need vaccination. So like flu vaccination to everyone. The second shot of Prevenar, if someone developed DKD, then you gave as a extra shot, but otherwise all of them they need it. DEXA scan, something which we are again forgetting, or not for only the patient with DKD, all patients, as a diabeto-endocrinologist, as a CKD, all patients we should do. So all those 10 things, even in a non-diabetes kidney disease, also anemia is very common. Please do it. B12 deficiency, also for chronic use of metformin. Please check all these things. So these are all very important points. It's not that just those who have developed diabetes kidney disease or CKD and then you start doing it. Please do it regularly, and then also the patient with diabetes kidney disease.
Yeah, I just have a couple of points to raise. One is diabetic kidney disease is definitely related to diabetes and all the comorbidities. So like now, we in India especially, like if you look at it, the composite control, the comprehensive control is very poor. So when do you start all these prophylactic or preventive strategies, or unless and until all the other comorbidities like blood sugar, hypertension, lipids, and even body weight reduction is not being achieved, is there any use in starting this Renal and all those things?
So as early as possible. One more point which I just want to make, Dr. Manisha. She told 7,000 transplant and some thousands of people who are on dialysis, but we know that only 10% of them actually could reach up to the stage of dialysis or in the transplant.
Yeah.
90% of the patient we lost on the process. And the patient who have developed diabetes kidney disease 2 creatinine with the eGFR 40 or 30, he will not be lucky enough to reach at the stage of transplant or dialysis. 90% of them will die before they will get a chance of a dialysis, and very few will able to get the transplant. So that's also very important. So in the process also we lose 90%, and then your question.
Yeah, so that's what there's a saying among nephrologists that those who come to the dialysis or transplant stage are the lucky ones who have escaped cardiovascular death. So I think his question is very important. See, primordial prevention. I think in all fora we talk about it but never practice it. Implementation is required. We need a healthy lifestyle which includes weight management, stress management, sleep management, not only for patients, for all of us as well. So I think that's where we are failing. We talk about it, we give lectures in schools, but go to the school canteen, what are they serving? They are not serving salads, they are serving all fast foods, and our children are consuming that. Obesity starts there. So I think your question is very important, that the key element in all the societies is diet and healthy lifestyle first, and we should implement it, not only just talk about it, we should do it ourselves. We should set examples for others. Whatever I keep on telling my patients, see, I have been doing it for last 4-5 years. Before that I was not practicing it, and whatever my busy lifestyle, sedentary lifestyle, I'll take out time for at least half an hour, 10,000 steps, whatever. You can do it in any way, you can do it in front of the TV or whatever, but that is important. So your question is very, very important, and these strategies should start before they develop these complications.
Exactly, madam. One more very important point which I want to raise is that actually there is a novel anti-diabetic drug called imaglimin, which is known to prevent the interstitial fibrosis, both kidney and heart. And even in short-term studies, 90 days studies have shown that there is significant, animal studies have shown that. So both of you have not mentioned about that thing. So what is your take on that particular thing? Because it's cheap too when compared to Renal. Very cheap.
I know. So probably Dr.
And it
Bansi would
controls
like to talk
diabetes
about
as
it,
well.
Then I'll take, so my answer would be that as well.
You know, it is an anti-inflammatory. It works in
Yeah.
mitochondria.
Most
and
data is
the
on animal cells,
prevention,
yeah.
but still we don't have an outcome trial. And, you know, in scientific world, we have to show the data for that.
So yes, so that's my answer. If we follow evidence-based medicine, as of now we don't have the data. There was a talk on this in the last conference as well. Excellent lecture was given by one of the speakers on hemoglobin, the mitochondrial dysfunction and all that. But we are doing now studies on the drug. So we'll probably come out with the data. But as of now, yes, that's the reason we've not talked about it.
So, ma'am, we are getting regular signals from the site that our oration man is waiting. So, we can't keep him waiting for the oration. Thank you for your talk. Just one, recently we have published a paper in IGDCC, and almost 16 lakh data was analyzed from the HealthPlex data. And it showed that urine ACR was done only in 3% of the patients. So, that is still, that is a big alarm that 16 lakh patient and only 3% of them. This is a real world data. So, all of you can go through this presentation, and this is a very big missed opportunity. So, just wanted to highlight. Thank you very much.
Thank you.
Thank you.